These are the speakers this afternoon, and without further ado, I would like to introduce our first speaker, Dr. André Lalonde. Dr. Lalonde has pursued excellence in the practice of obstetrics, gynecology, and sexual reproductive rights for over 25 years. As Executive Vice President of the Society of Obstetricians and Gynaecologists of Canada, SOGC, Dr. Lalonde heads Canada's most specialized organization in the field of women's sexual and reproductive health. Dr. Lalonde is currently clinical professor of obstetrics and gynecology at the University of Ottawa and McGill University, and is adjunct professor in health administration at the University of Ottawa. He is the Federation International Gynaecologists and Obstetricians. He's a Canadian representative. He chairs that committee for safe motherhood and newborn health, and he's also an expert on newborn maternal health for the WHO. Considered worldwide as a leading expert of women's health, Dr. Lalonde has extensive experience in low-resource settings and has pioneered initiatives on maternal and newborn health, sexual and reproductive rights, and Aboriginal issues. And he's lectured in developing countries around the world. Dr. Lalonde has developed an expertise and is an advocate for safe motherhood and newborn health, as well as promoting women's empowerment for reproductive health. He currently serves on Safe Motherhood International Committee and oversees the SOGC International Health Program. So please join me in welcoming Dr. André Lalonde.
Thank you very much. I'm very pleased to be here today. I wanted to present to you the position of the SOGC on these issues that are just been presented. It's written draft policy statement because our board is going to be approving this in about 2 weeks in Vancouver. I'm pretty sure it's going to probably remain pretty well similar. So the objectives is to discuss the appropriate testing of drugs for use in men and women in Canada and our position, the Society of Obstetricians and Gynaecologists of Canada, and advocate for testing of drugs used during pregnancy exclusively by women. And this has been mentioned as one of the objectives, I think, of the discussions today. The Society of Obstetricians and Gynaecologists of Canada is always cautious with the choice of pharmacological treatment recommended during pregnancy. The SOGC welcomes the increased choice available to a woman with the introduction of generic formulations that have been shown to be bioequivalent to current available brand name formulation, as this provides less expensive options to Canadian women in need of drug therapy. According to Health Canada, bioequivalence implies that the drug product should have the same systemic exposure and effects, both therapeutic and adverse, as a reference product when administered to patients under conditions specified in the labeling. When testing bioequivalence, an important objective of the selection of subjects is to reduce the intra-subject variability in pharmacokinetics that may be attributable to certain characteristics of the subject. And to quote them, subjects should be assigned in such a way that the study design is balanced for any factors that are suspected to contribute to variability. So really, I think Health Canada, if they look at the and the FDA, recognize that there is a lot of variability in the studies between men and women, and more than 30% of the studies reviewed would not have passed the bioequivalence criteria for one sex when it did for the other. And I have some examples here. For example, here you can see the intra-subject variability. This comes from a number of studies. You can see the drug, alprazolam, cimetidine, erythromycin, naproxen, all drugs that are commonly used. And you can see the difference between men and women. In some cases, there's a 6-fold difference. And so therefore, I'll come back to that and why we believe that the number of men tested for the approval of these products should be much higher than it is presently in Canada. The other factor that we have looked in addressing this policy is this graph here, where you can see that certain drugs have been tested, and these drugs are only used in women, and therefore the testing group was healthy, non-pregnant women, which is fine. And in some cases, as the last two drugs here for erectile dysfunction, they were only tested on normal males. So this is an important point for us because we believe that in the advocacy role that we have, the SOGC, we should advocate for testing with the proper patients. So if a drug is only going to be used for a woman, it should be tested by women. Presently in Canada, there is no specific regulation for preferring female subjects over male subjects when studying drugs aimed at women only. This could lead to serious errors when interpreting bioequivalent studies performed in men or in combination of male and female subjects. Hence, a generic formulation may be approved by Health Canada based on an inadequate assumption that variability in both sexes is similar. We're especially concerned about the small numbers. A recent survey of our members has shown that our members believe that introduction of a generic product, probably a couple of hundred or 1,000 patients were tested. When they're told that 14 patients only are tested, this is really causing quite a bit of concern amongst the clinicians. Very difficult to understand. If the 20 patients are made up of 4 women and 16 men, and you take the average of this and you apply this, then we have some serious questions into whether this is adequate or not. Health Canada requires that a generic formulation be bioequivalent to the innovator formula when a drug is intended for treatment of pregnant women. Presently, bioequivalent studies uses men and women and are approved based on the average, as I just mentioned, and we believe that this is wrong. If a sex by formulation interaction occurs, the safety and efficacy of the generic formulation could not necessarily be considered equivalent to the reference formulation. These difficulties are even more evident for bioequivalent studies in pregnant women, which are almost non-existent. There are currently no specific requirements for the approval of drugs intended for vulnerable populations, such as pregnant women. In addition, there are no requirements to disclose the prescriber the exact population used in bioequivalence, and that's a real concern for clinicians across the country. So some of our recommendations, we believe that drugs that should be used exclusively in men or women should be tested in a small number of men and women. We don't agree that this should be done in that way. We believe that if they're going to be used only in males, then as they've done in the past, they should be tested on males only, but should be tested in an adequate number. We're worried about the numbers. We are asking for higher numbers than are presently occurring. We don't have any probably scientific proof for this, but we have common sense proof that you should be testing a drug more than in 14 people. The SOGC does not believe that drugs should be substituted without the patient and the physician both agreeing to such a change. We all have clinicians who report to us that their patients are having secondary effect. They don't know why. They've been prescribed always the same medication. They've been taking the same birth control pill, for example, or same hormone therapy pill for 3 years, 4 years, 5 years, and all of a sudden they have side effects or complications. And you must remember that in our specialty, especially with estrogen, the extremely low doses. Birth control pill is down to about 10 to 15 microgram. So if a product can be 80% to 100% similar to a given product, well, if it's at 80% or 120%, it means a lot when you only have 1.5 microgram. So this doesn't seem to be taken into account. The other substitution that's occurring in Canada is for price only, and we believe that's unacceptable, especially for drugs that have been tested in very few subjects. Sometimes, as I said a while ago, as listed as 15 to 20 patients, and sometimes tested both in male and female. So the SOGC as a policy organization that is responsible to advise its member on clinical practice have the following conclusions. We call on Health Canada to review its guideline on testing drugs for vulnerable population, especially pregnant women. We'd like to see a policy established here in Canada, and I was pleased to see that you have submitted issues 2 years ago, and nothing has happened, and you can believe that our society will be making pressure on the new government to give us answers. The second recommendation, probably a little controversial, that testing standards should be set at minimum at least 100 or more patients, and I'm talking not about just the kinetics. The kinetics could be 15 or 20 patients, but the kinetics is only part of the solution, because you can have something that is stable in 15, 20 patients, but when you come to the clinical practice, you have tremendous variability, obesity, pre-diabetic, etc. So we would like to see the generic formulation tested in more patients to make sure that it is equivalent to the brand name. So we believe that errors could be introduced when you're mixing testing in male and female population. So finally, our call to action is that healthcare professional and women's groups that we work with, we advocate that the Government of Canada establish an ad hoc committee to look at the recommendations in the way drugs are tested for women in general, but specifically for at-risk groups, and here we're talking about the female population and the pregnant population. Thank you very much.
Are there any comments or questions for Dr. Lalonde?
Chen, yes. Okay. But I've got about 12 different references. I must say that because I'm addressing this from the policy issue, obviously I'm opening this up for discussion because you are the experts here in the study of medications and pharmacokinetics. But we want it to be a little controversial, and that's why we're putting this up. But it's a good question. Anything else?
Sorry, Giddy, could you just speak in the mic so they could be recorded, please? Thank you.
I want to congratulate SOGC and yourself for taking that step, because we are clinicians, scientists, and your organization is the most important organization to care for pregnant women. And unless you take a strong stand, as you did in the past on other important issues, the government, I don't believe, will move. As you said, 2 years after we submitted similar documents, we hardly got any, well, there was some response, but clearly it didn't lead to any serious discussion. So I'm very happy with this.